The following podcast is part of a certified educational activity titled Mastering the Art of Referring Pediatric Patients with Eosinophilic Esophagitis to Specialty Care for Timely Treatment, Spotting the Signs. Access the entire activity and complete the post-test at peerview.com/KVY860. Downloadable practice aids are also available.
Hello, this is Sophia Patel from the Cleveland Clinic Children's Hospital. Welcome to this educational activity on spotting the signs, mastering the art of referring pediatric patients with eosinophilic esophagitis to specialty care for timely treatment. Our goals for today are to improve your ability to identify the clinical presentation and diagnostic criteria for EOE in pediatric patients. We'd like to enhance your knowledge of the association between EOE and other atopic disorders, including asthma, atopic dermatitis, and allergic rhinitis. We want to equip you with skills to refer pediatric patients with suspected EOE to a specialist in a timely and appropriate manner, and augment your understanding of the use of biologic therapy and the management of appropriate pediatric patients with EOE. EOE has been rising in prevalence, and it is very important to have timely referral and diagnosis of this disease. The updated EOE guidelines that were originally published in 2011 define eosinophilic esophagitis as a chronic immune-mediated, antigen-mediated disease that is characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil-predominant inflammation. EOE is a clinical pathologic disease that has to be diagnosed with biopsies taken in the esophagus for confirmation. On pathology, one or more biopsies have to show eosinophil-predominant inflammation, including greater than 15 eosinophils in each high-powered field. The disease is usually limited to the esophagus, and other causes of eosinophilia need to be excluded, including hypereosinophilic syndrome and parasites. In this graph, you can see that the EOE prevalence of the disease is increasing over time. This systematic review that was done in 2018 confirmed that EOE is a very common disease, but is less common in children than in adults. The prevalence rates have been increasing over time, and the rising prevalence can be attributed in part to ongoing rise in incidence rates and also knowing more about the disease. However, the prevalence is beyond what you would expect in changes in the definition to EOE over time, including initially excluding patients who responded to PPI therapy, and it is beyond the increase in rates of endoscopies being performed over time and biopsies being done in all endoscopy patients. The increased prevalence is mainly reported in the US and Europe, but has also been noted to happen in other countries, but it could also be a reflection of a lack of resource allocation in those countries. The epidemiology and prevalence of EOE shows that it can occur in really any age range, but primarily we see it often in adolescents and young adults, and it is more common in males and then females. It can affect all races of patients, but it is more common in Caucasians. And while it is more common in adults, children often have more nonspecific symptoms that can elude diagnosis, especially if not investigated thoroughly with a high level of suspicion. EOE varies in presentation by age. Younger children often have more nonspecific symptoms, including feeding disorders, issues with vomiting, abdominal pain, weight loss, and overall oral aversions. And older patients often present more often with abdominal pain, dysphagia, and food impactions, especially as they become more like teenagers. These are not the only symptoms that they report, but often are the primary complaint at referral. Longitudinal observation of these patients over time who have been untreated has not been done and needs to be done in the future to help understand the progression of disease. Environmental factors are known to be a major source of eosinophilic changes in patients, especially with other atopic symptoms. There's a lot of different cogs to the wheel of EOE. Atopic patients are generally at higher risk of having the disease compared to patients who don't have atopic diseases. There is a known seasonal variation with EOE as well. Early life factors have shown that C-section, preterm delivery, maternal fever, and exposure to acid reflux or antibiotic therapy as infants can increase your risk of development of EOE. Also, the lack of early exposure to microbes, which goes back to the hygiene hypothesis, has been shown to be a protective factor to EOE, and patients who typically have furry pets have a lower incidence of developing this disease, and similar to other atopic diseases. One of the helpful acronyms that is used to remember EOE symptoms is IMPACT, and it can help in determining over time how they've adapted their behaviors to help mask their symptoms of EOE. Oftentimes, they will imbibe or drink fluids to facilitate the passage of solid food. They'll modify their foods, including cutting it into small pieces and pureeing it or avoiding certain foods that are harder to chew. They prolong their meal times, meaning that they have difficulty with eating fast and often take a very long time to eat foods. They avoid harder texture foods. They chew excessively, and they don't like to take pills or tablets, and they turn them away due to their concern for them becoming impacted. The role of the pediatrician is very important because they are the gatekeeper to sending patients to the gastroenterologist. They will typically see the patients initially for their first symptoms, which are oftentimes abdominal pain, nausea, vomiting, or even in older patients with specific symptoms of dysphagia. After the patient is identified to have these GI symptoms, most of them are referred for evaluation by a gastroenterologist, and endoscopy and biopsy is required to establish a diagnosis of EOE. Due to its chronic course, EOE management requires very long-term therapy and also a multidisciplinary approach along with regular follow-up. Timely referral is very important in EOE, mainly because the longer the disease is present, the more likely the patient can develop worsening symptoms, including fibrostenosis and esophageal narrowing from this disease. In this study by Dr. Chehade in the Journal of Allergy and Clinical Immunology from 2018, the evaluation of 705 patients with EOE from age 6 months to 65 years, they reported that the time gap increased as patient age diagnosis increased. The average age that symptom onset to diagnosis was 4 years in adults, 2 years in patients 11 to 17 years of age, and 1 year in children less than 11 years of age. The presence of a food allergy or atopic syndrome like atopic dermatitis was associated with a more prompt diagnosis and was more common in younger populations. The time between symptom onset of EOE and diagnosis ranged between 1 to 3.5 years in children and 3 to 8 years in adults. So the referral for the gastroenterologist should happen in a more timely manner because over time, EOE can progress into a disease that has more fibrostenosis and issues with dysphagia and chronic fibrotic changes. The AGREE guidelines were released in 2018, and it helped clarify the diagnostic algorithm for EOE. In patients who have a clinical presentation that's suggestive of EOE, they should have an EGD with biopsy. If esophageal eosinophilia is noted at greater than 15 eosinophils per high-powered field, the patient should have evaluation for non-EOE disorders that cause or potentially contribute to esophageal eosinophilia, like hypereosinophilic syndromes or parasites, and they are diagnosed with eosinophilic esophagitis. These guidelines help clarify treatment for EOE as well, and they help define the difference between patients who responded to proton pump inhibitors and help guide some of the treatment that we do even today. The importance of a multidisciplinary approach to management of EOE is to know that the disease is very heterogeneous. It can involve multiple systems of the body. It frequently co-occurs with atopic comorbidities, including food allergies, asthma, atopic dermatitis, and there's a variety of assessment and treatment approaches that might be indicated. So the patient not only interacts with their gastroenterologist and their allergist, but they also have help with their primary care physician or their pediatrician, maybe a nurse practitioner. Maybe they're already seeing a feeding therapist for oral aversion in younger patients, or a dietitian because they're malnourished, and also a pathologist who can help us determine whether they have the correct number of eosinophils under the microscope for diagnosis. The comprehensive management of pediatric EOE involves evaluating comorbidities, type 2 inflammation, and looking at the use of biologic therapies. The goal of treatment of EOE is to treat to help patients' symptoms, histologic activity, and endoscopic activity. Our goal is to help resolve symptoms that are attributable to EOE, including dysphagia, abdominal pain, and nausea, have histologic activity, including resolution of the esophageal eosinophilic inflammation, and improve the endoscopic activity in these patients as well. This study recently released in the American Journal of Gastroenterology determined new guidelines to the management of eosinophilic esophagitis and was published by Dr. Dellon and his colleagues. After the EOE diagnosis is established, the treatment should be initiated for inflammation and assessed for fibrostenosis in all patients. The next step would be to choose an anti-inflammatory treatment, which can vary between pharmacologic treatment or dietary elimination, and this should be determined by shared decision-making between the provider and the patient. Pharmacologic treatment can be divided into proton pump inhibitors or topical steroids. In patients who don't respond to those after they have an endoscopy, they can be either then switched to dupilumab or change or modify their prior treatments. After this, they should continue to have response assessment, and they can continue to go back to discuss what other options for treatment there may be. Another portion of the anti-inflammatory treatment is dietary elimination, which can include empiric elimination of different foods, and we'll get into that a little bit later on in the talk. And most importantly is reassessment of fibrostenosis in these patients to ensure that there are no narrowing or esophageal strictures that are needing to be treated as well. And in some of those patients, having an endoflip performed, which is a functional luminal imaging probe that can assess the distensibility of the esophagus during their endoscopic assessment, can be helpful as well. PPI treatment has had a lot of controversy in EOE. Many times in the earlier part of the disease, it was thought to be one of the same as acid reflux, but we know that PPI treatment is a singular different treatment for EOE. And it can do so much because it has so many anti-secretory effects. It blocks the expression of adhesion molecules along with inflammation. It blocks STAT6, which modulates eotaxin and eosinophil recruitment, and overall can improve the barrier function of the esophagus, along with decreasing the acid production that can worsen eosinophils in the distal esophagus. In PPI therapy, we have observational studies that evaluate patients who are on PPIs. Most of the studies were non-comparative and retrospective. 12 studies overall note histologic response rates of up to 42% of patients who are on only PPI therapy, and about 30% of pediatric patients respond to only PPI therapy. Food elimination diets have evolved over time in EOE, and initially elemental diets were thought to be the best choice for dietary elimination. This involves removing all foods and starting a hypoallergenic amino acid-based formula. It has very high remission rates, but as you can imagine, it's unpalatable, very expensive, and there's a big challenge with food reintroductions. After the original studies looking at elemental diet, we know over time that empiric elimination is more commonly used to treat EOE. And the empiric elimination is better tolerated and can be increased stepwise, starting with 1 food, 2 foods, and so on. The most common foods that we know are triggering EOE are milk, wheat, eggs, and soy, and less often peanut and tree nut and fish and seafood. In a 1-food elimination diet, milk is the preferred starting food, and in a 2-food elimination diet, milk and wheat are the 2 preferred starting foods. In those patients, you can divide them up into a step-up elimination diet and a step-down elimination diet. A step-up elimination diet starts by eliminating 1 to 2 foods for 6 weeks and then repeating endoscopies after that time. If the endoscopy shows that there are greater than 15 eosinophils per high-powered field, then additional foods are added and reassessment is done. And this is helpful because it does limit the amount of endoscopies that the patients have. The step-down elimination diet is more restrictive and starts with a 6-food elimination, and every food that is reintroduced has an endoscopy following reintroduction, which adds more and more endoscopies, and unfortunately, that is one of the risk factors of patients who have EOE to have multiple anesthesias and endoscopies for this. So we try not to do the step-down as much as we do the step-up elimination diet. In a multi-center randomized control trial from 2024, children with active EOE were randomized to either a 1-food elimination diet with dairy alone or a 4-food elimination diet. After 12 weeks, they were evaluated based on symptom scores, histology, psychosocial scores, and the transcriptome, and they were found to have similar improvements on a 1-food elimination diet versus a 4-food, with up to 40% noted response to each therapy. So we know that a single food of elimination can be enough to treat EOE in these patients, and you may not have to be on such a restrictive diet. Recently, the AGA guidelines showed that topical corticosteroids should be used over no treatment as another treatment option for patients with EOE. Histologic remission rates may vary depending on the formulation and delivery of the medication, but it can be as effective as up to 84% response rate. These medications provide a topical coating to the esophagus and are very safe compared to systemic corticosteroids. There are still some adverse effects to discuss with patients, including esophageal candida infection, decreased bone density, adrenal insufficiency, and decreased linear velocity. Overall, you want to avoid using systemic corticosteroids in patients with EOE, and the preferred method is to use topical corticosteroids for treatment. The current options for treatment of patients with EOE with topical corticosteroids include fluticasone, budesonide, ciclesonide, and budesonide oral suspension. And that was recently approved in children greater than the age of 11. There's also a phase 3 trial of fluticasone oral disintegrating tablet that is underway. In this study evaluating the budesonide oral suspension, patients with EOE and dysphagia were randomized 2-to-1 to receive either budesonide oral suspension or placebo. In the groups that were randomized, they split them up into 213 patients who received budesonide oral suspension and 105 who received placebo. The patients had good response, with up to 50% responding with less than 6 eosinophils per high-powered field on evaluation. And the dysphagia response score was 52%, which was almost 10% higher than patients who were on placebo. And we know that that is an important part to make sure that patients are also having symptomatic treatment as well as histologic response. EOE is related to many other diseases that are regulated by type 2 cytokines, which can include IL-4, IL-13, and IL-5, and other downstream regulators. They cause similar symptoms of barrier dysfunction, tissue remodeling, smooth muscle hyperplasia, increased inflammatory cell trafficking, and IgE production across other atopic diseases such as asthma, allergic rhinitis, nasal polyps, chronic rhinosinusitis, and atopic dermatitis. Atopic comorbidities are very common in patients who have EOE. Up to 78% of patients in EOE have at least one atopic disease, and up to 50% report having greater than one atopic disease associated with EOE. Some 22% have reported having 3 atopic conditions. A history of food allergy or atopic dermatitis is associated with a significantly shorter time between symptom onset and diagnosis. And in patients who have atopic disease, they should have assessment for EOE, especially if they have symptoms of esophageal dysfunction. The pathophysiology of EOE is complex, but it is still mediated by similar Th2 pathways that recognize eosinophils in the esophagus. Oftentimes, food triggers, including milk, wheat, and eggs, environmental triggers such as microbes, seasonal allergens, and genetics all play a role in triggering the esophageal tissue to set off a cascade that activates Th2 and T regulatory cells that then, through multiple pathways, trigger eotaxin-3, STAT6, STAT5, and SMAD, which decrease the barrier protection of the esophagus, and SMAD and periostin, which worsen esophageal tissue to cause remodeling and also cause eosinophilic inflammation through the eotaxin-3 pathway. Now we'll take a look at a brief 3D video on the role of type 2 inflammation in EOE and the mechanism of action of targeted therapy.
Eosinophilic esophagitis, or EOE, is primarily driven by underlying type 2 inflammation, characterized by immune dysregulation and epithelial barrier dysfunction. Mediators of type 2 inflammation include eosinophils, mast cells, Th2 cells that produce the cytokines IL-4, IL-5, and IL-13, ILC2s, and IgE-producing B cells. Th2 cells are a subpopulation of CD4-positive T cells, which secrete IL-4, IL-5, and IL-13 and stimulate the type 2 response. IL-4, IL-13, and IL-5 are key drivers of type 2 inflammation in EOE. IL-4 and IL-13 also contribute to the activation of mast cells and basophils, leading to the release of several inflammatory mediators. IL-4 and IL-13 drive epithelial barrier dysfunction, facilitating the entry of antigens that can worsen inflammation and increase access to allergens and pathogens across the epithelial barrier. They then propagate local inflammation, resulting in remodeling and fibrosis, such as furrows, distinct rings, edema, exudates, strictures, and increased smooth muscle contraction. IL-4, IL-13, and IL-5 also contribute to eosinophil activation and trafficking to tissues. IL-5 drives eosinophil differentiation in the bone marrow. Dupilumab is a fully human monoclonal antibody that binds to the shared alpha subunit of the IL-4 receptor and therefore inhibits IL-4 and IL-13 signaling. By inhibiting IL-4 and IL-13 signaling, type 2 inflammation is reduced, decreasing eosinophil count and improving symptoms of EoE, including difficulty swallowing, for patients.
Dupilumab is a newer biologic therapy that acts at the IL-4R alpha subunit to decrease signaling of IL-4 and IL-13. Through this pathway, it helps decrease the Th2 pathway that we reviewed in the former slide. It's been approved in the United States for treatment of moderate to severe atopic dermatitis, asthma, chronic rhinosinusitis with nasal polyps, prurigo nodularis, and more recently has been approved for the treatment of eosinophilic esophagitis in ages 12 and over in May 2022 and ages 1 to 11 in January 2024. In the Phase 3 KID study, which looked at dupilumab in children ages 1 to 11 years, patients were randomized to receive higher exposure of dupilumab placebo and lower exposure regimen of dupilumab, and then followed in long-term trials up to 108 weeks afterwards. The Phase 3 KIDS trial was studied to evaluate the efficacy and safety of dupilumab versus placebo, and the patients were randomized in equal groups. In these studies, dupilumab was shown to improve histologic and endoscopic features of EoE, as well as increase the rate of weight gain in patients. And you can see that the patients had an improvement in their peak eosinophils for high-powered field, with up to 70% of patients on dupilumab having less than 6 in each segment. They also evaluated the EoE histologic scoring scale grade and stage score, and they all had significant changes in that histologic scoring scale compared to placebo patients. And there was an absolute change in the EoE EREFS endoscopic visual scoring scale compared to placebo. And patients also had significant improvement in days with greater than or equal to 1 EoE sign on a daily basis. And they also had an improvement in their body weight for age percentile, which is very important in younger children who especially have oral aversions and weight loss due to the disease. Overall, adverse effects were 80% with dupilumab, 91% with placebo, and none of the patients on dupilumab required study drug discontinuation despite the adverse effects. Dupilumab should be considered in the first line in patients who have multiple comorbid atopic conditions, including asthma, atopic dermatitis, chronic rhinosinusitis with nasal polyps, or a strong preference to avoid dietary restriction or topical corticosteroids. Dupilumab should also be considered as a step-up therapy in patients who have very difficult to treat EoE, failure to thrive, poor growth, or significant weight loss due to EoE, frequent use of rescue therapies, severe dietary restrictions, or requirement for an amino acid formula, clinically significant esophageal strictures or narrow caliber esophagus, patients who are refractory to current therapies or they have adverse effects from current therapies. Another medication that is undergoing evaluation in trials is cendakimab, which is not yet FDA approved. It is also a monoclonal antibody that is selective for IL-13 and inhibits the binding of IL-13 to the alpha-1 and alpha-2 receptors. It is also given as a weekly injection, such as dupilumab is. It inhibits IL-13, which is one of the major pathways that also triggers from the Th2 pathway in EoE. It also had good improvement in symptoms, histologic and endoscopic features in EoE in a 24-week study, including a change in dysphagia days, a decrease in eosinophils to less than 6 per high-powered field in up to 28% of patients. They also had a histologic response rate of less than 15 and over 40% of the patients, They also had significant improvement in their ERAF score, which is the endoscopic visual score, and changes in their histologic scoring scale in the grade and stage, along with the change in their median dysphagia scoring days as well. In summary, EOE continues to increase in worldwide incidence and prevalence. Pediatricians and primary care providers are critical in identifying symptoms and are often the first line in referring patients to gastroenterologists. EOE is a progressive disease. It starts with inflammation and can progress to fibrosis in most, but not all patients. And patients with early diagnosis and ongoing therapy are less likely to develop fibrosis and reduce complications. Targeted biologic therapy like dupilumab is now available for patients 1 year of age and older with EOE, and others are in development. Thank you so much for joining me, and I hope you found this activity to be useful to your practice.
Thank you for listening. Remember to download the practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/KVY860.